Welcome back. My next guest is Dr. Igor Voskresensky. I always have trouble with that, and I probably butchered it, but your patients know you as Dr. V, and you are with Fayette Surgical Associates.
Yes.
Welcome.
Thank you for having me here.
Now, you're a vascular surgeon, and one of the things you do is deal with aneurysms. Now, we've all heard of thoracic aneurysms, abdominal aneurysms. Well, tell us what that actually means.
Well, Jeff, there's a big blood vessel in your body. It comes out of your heart, makes a loop in your chest, and goes all the way down. And it's like a big garden hose, and it brings all the nutrients and the blood and oxygen to your organs. And that garden hose sometimes develops a bulge, and that's what an aneurysm is. It's a dilation of an artery.
Now, you brought a little device there with you, and that's actually an anatomic model, and you can see the bulge is the aneurysm?
Yes, sir. So this is a model of an infrarenal and a common iliac artery aortic aneurysm, and this is very common. So an infrarenal aneurysm and a common iliac artery aneurysm. These are the two little arteries that go to the kidneys, and actually what you see here is what an endovascular repair would look like inside the patient when we fix an aneurysm.
Now, you mentioned that because when I was first training, there was no such thing. You had a big abdominal surgery and repair it all. But you brought with you I would call it a simple way to repair an aneurysm. Tell us about it.
I did, yeah. So in 1991, the first endovascular repair was performed, and since then, multiple iterations of devices came on the market to help us treat this particular problem. And so what we strive to do here is basically place another garden hose into a garden hose that has a bulge in there. And so our goal is to achieve seal and fixation so that the blood flow can now go through this combination of pipes into the lower extremities.
Well, like you say, your patients always ask you, how do you get that thing in you? You're going to show us?
Yes, absolutely. So this is one of the devices that we typically use. So this is a Gore Excluder endograft, and this is the device that is constrained onto this long catheter. And so now what we can do is, as opposed to, like you mentioned, making a big incision in the abdomen, now we make two small incisions in the groin, and we deliver this device below the kidney arteries utilizing this. So if you help me, we can show the patients how we actually do that. So there's several different steps, obviously not as simple as it is here, but the idea is the same. So you see how the device is opening up. It's obviously done under X-ray with the patient frequently not fully asleep, which makes it easier for the patient to recover from anesthesia. So multiple little pieces here, but you'll see the device will fully open up here. And then the device stays inside the body just like this. It's fully opened up. And so now we have deployed this endovascular graft. It sits below the kidney arteries. It has little hooks which allows it to stay fixed. And then the second portion of this procedure, so let me put this delivery system away. If you hold this here, we got to complete our pair of pans. And so this is the second part. We'll be able to line up the graft here. So if you hold the device, and we'll deploy our second portion here, which is a little bit less complex. And here you have it. So this is what stays inside the patient, and you can feel how flexible this is. This is basically a material called PTFE, so fancy jackets that you see. This is the medical grade of those Gore-Tex jackets.
And that's actually what's right in there.
That's exactly what it is, yes, sir. So
right there.
These are the devices that, or one of the devices that we use to treat this problem. The procedure usually takes about an hour to an hour and a half, and you know, compared to an open operation, the risks associated with this are significantly lower. So one of the common things we'll see sometimes is what's called an endo leak. And basically, as I mentioned, you want to achieve seal and fixation, but occasionally the blood can leak, either from below in the endograft or from above, and we see that on postoperative imaging. So there has to be a follow-up for patients, and I tell patients that once I operate on them, we're kind of best friends forever. Meaning that I see them from there on because it's a human-made device in the human body, and we want to make sure that it doesn't have migration and there are no leaks that develop over time. And so we follow these things, and we expect the aneurysms to shrink if the procedure is done correctly.
Well, you know, that's just great technology and works great. But how do we know if we have an aneurysm? What kind of symptoms might we have?
So, believe it or not, vast majority of aneurysms discovered now are asymptomatic, and they're discovered incidentally. So over 60% of patients who come to our office were found by incidental studies. So you might have had some reflux or some gallbladder type symptoms, and you underwent a CT scan, and lo and behold, an aneurysm was discovered. And so most patients, this is found incidentally. Now, there are some recommendations about who are the patients that should be screened for aneurysms. And so one of the risk factors, for example, the biggest one is tobacco. And so patients who have history of smoking and who are over 65 are recommended to undergo an ultrasound screening. Now, patients who have family history of aneurysmal disease are also at risk of developing aortic aneurysms, and so those patients may need to be screened sooner.
Well, that's really just great information. If you have a symptom, though, what might that symptom be other than nothing? Of
course. So some of the symptoms that patients can experience is back pain. And we see a lot of patients who have back pain due to degenerative disease. And this back pain may not necessarily be anything out of the ordinary. It could be just dull, unusual discomfort that patients experience in their back. They can have pain in their abdomen. Pain could radiate down into the groins. So those symptoms we take very seriously, and we evaluate patients for this kind of pathology.
And if you have an aneurysm, I would say they'll probably come see you. Not all aneurysms need to be fixed,
Absolutely.
But as they grow, you might need to think
Yeah,
about it.
just like a balloon, you put enough air into a balloon, eventually it's going to rupture. So when you mentioned about thoracic and abdominal aneurysms, this is what we're trying to prevent. We're trying to reduce the risk of rupture. And so smaller aneurysms we can safely watch. The rate for small aneurysm rupture is low, but as the aneurysm grows, our antennas go up, and we want to make sure that we catch those patients before something devastating like a rupture occurs. And so we're able to follow them either with ultrasounds in our office or CAT scans, and able to counsel patients on what their risks are, how we potentially can fix their problem, what are the perioperative and postoperative expectations. So like I said, we become best friends, if you will.
It's great work. We thank you for coming in. Appreciate the work you do.
Pleasure.